I'm Professor Molly, and I am going to discuss arrhythmias. This section is going to be specifically for the atrial arrhythmias that occur above the ventricles. So we're going to discuss the signs, the symptoms, what causes them, and how to treat them. Now we're going to get into some arrhythmias. So this is where, if we're going to talk about the atrial arrhythmias, this is occurring above the heart. When you're assessing your patient and the rhythm strips, you want to make sure if they're symptomatic or asymptomatic. And this is going to be a very important thing of how you're going to treat them. So no matter what the arrhythmia is, no matter where it's occurring, you have to know if your patient is feeling the symptoms and note what the symptoms are, or if they feel completely fine and they're asymptomatic. And that's going to determine your treatments. Now let's get into the sinus arrhythmias. And when you're talking about sinus arrhythmias, this occurring, it starts in the SA node. Sometimes there's a block or a delay, and you can see sinus arrhythmias, which is an actual beat occurring before a PQRS complex, occurring before it regularly should have happened. Or you could see a delayed conduction through the SA to AV node, which you can find in sinus bradycardia. And again, you want to assess the patient if they are symptomatic or asymptomatic. But when you have dysrhythmias that are occurring in the atrium from a fibrillation or an atrial flutter, which is a disorganization or a very fast tachyarrhythmia in the atrium, you will then start having cardiac output problems. And this will lead into the patient having severe symptoms and not being perfused adequately. And so we're going to delve into what occurs here and how we treat them. Let's look at atrial fibrillation first, so you can see the difference between the two. Atrial fibrillation is total disorganization or a fibrillation of the atrium, and it is a quivering line. So when you look at a VFib and we have a quivering line, this is the atrium quivering, and you will not be able to measure a P wave. The P wave is going so fast, it can be up to 600. What you want to do is we're going to be looking at the ventricle rate, which is the QRS complex. We're going to be measuring the R waves here. Again, we're going to be looking at a 6-second strip, and we're going to count the R waves. And that's what's occurring in atrial fibrillation. What's occurring in flutter is that we're having a tachyarrhythmia in the atrium. It is not fibbing, it is very fast. So it is a little slower than fibrillation, and it is very similar to a ventricular tachycardia, but it's occurring in the atrium. So it's an atrial flutter. And what it looks like is like a sawtooth or a wavy appearance, and the atrium is beating around 2 to 350. Again, we're going to be looking at the ventricle rate because we cannot measure the atrial rate in either one of these rhythms. Now we've identified atrial fibrillation and atrial flutter, what they look like. The course and the treatment is going to be exactly the same for both of them. Now, the first step is going to be finding out if your patient is symptomatic or asymptomatic. If they're symptomatic, they're going to be feeling fatigue. They could have shortness of breath. They will have a very high heart rate. Typically, their ventricle rate will be over 100. They will have anxiety. They will have a low blood pressure and possible palpitations. They're not going to feel good. They can also be sweaty and diaphoretic. So why is your patient symptomatic and feeling horrible? Is because they're not perfusing their body. Their cardiac output is low. And this occurs when the ventricle rate is over 100, when they have rapid ventricular response. So that ventricle does not have enough time to get enough blood from the atrium because it's quivering and not squeezing adequately. And the ventricle is contracting at a very high rate and trying to perfuse the body with not enough blood in it. So when it squeezes, it's not perfusing a lot of blood because the atrium did not squeeze properly to give it amount of blood. So it passively drops into the ventricle. So if it squeezes and doesn't have enough time to fill with enough blood and it squeezes too fast, you're not going to perfuse the body. So your cardiac output is going to be low, and they're going to feel the symptoms of this. So we have to treat them. If we know that their atrial fibr flutter occurred onset less than 48 hours and they're symptomatic, we can electrocardiovert them. We can try to shock their heart rate back into a normal sinus rhythm. However, if they have had AFib or aflutter longer than 48 hours, they're going to have to be on anticoagulants up to 3 to 4 weeks before we electrocardiovert them. So we're going to put them on a rate control. We're going to slow their ventricular rate down by giving them a calcium channel blocker like ditalazem, or we're going to give them a beta blocker like metoprolol to try to slow their heart rate down to give that ventricle enough time to fill. The other thing we have to do is we have to give them a blood thinner. We have to give them anticoagulants so they do not throw thrombus. When that atrium quivers and the blood is pooling, clots will develop. And if we do not put them on a blood thinner and give them anticoagulants, then they will shower clots to their brain, causing a stroke, to their heart, causing a MI, or to their lungs, causing a PE, or other areas in the body, causing a lot of problems. So these patients have to be on a blood thinner. Those are the main treatments for these patients. One more difference between atrial fib and atrial flutter is one is irregular. Atrial fib is irregular. So if you were to march out the R waves, you would note that this rhythm is irregular. But atrial flutter is typically regular. So what will happen is it's going to be in a ratio where you're going to have these flutter waves that look again like can be a sawtooth. But if you look at this rhythm here, this is a 2-to-1 conduction. And so you may have like 2 flutter waves to 1 QRS complex. So that's a 2-to-1 ratio, but your R waves are going to march out because it's going to be regular because it's in a ratio pattern. You can have a 3-to-1 and a 4-to-1. So that is another difference when you're looking at these two and the difference between the flutter and the fib waves, but also you need to look at the QRS complex. Okay, let's talk about paroxysmal supraventricular tachycardia. That's a mouthful, isn't it? Okay, otherwise known as SVT. So let's say that. So this is a AV block that prevents the impulse to conduct to the ventricle. Usually it's happening above the bundle of His. And you can tell from the complexes that they're narrow because it's occurring above the ventricles. Things that are occurring in the ventricles are going to have that larger QRS complex, that wide QRS complex. This is narrow. So the QRS complex is going to be usually less than 0.12 seconds. And so people with Wolff-Parkinson-White syndrome they are the most common people with PSVT, and usually adults greater than 65. So the heart rate is very fast, and they are as high as 220 beats a minute. Now, some typical causes is physical exertion, some people that have a lot of caffeine, stress, nicotine, other CNS stimulants. But if this occurs, you have to ask them if they're symptomatic or asymptomatic. And when somebody's symptomatic, again, that's when they feel the effects of this. They're feeling bad and they're not getting enough cardiac output because there's not enough blood. Their heart is going too fast to push the blood out, and it doesn't have enough time to fill in the ventricles. So their heart is going too fast and they're going to feel the effects of this. So if they're not stable, and if their heart rate is usually typically over 180, then you're going to see a decreased cardiac output and a blood pressure. And they're going to feel the symptoms of this. They're going to feel palpitations, they're going to feel short of breath, and they're probably going to feel the chest pain from the angina, from them not having enough time to fill those coronary arteries, from the left ventricle not having enough time to fill because it's pumping so fast. So we need to treat these people. So if they are asymptomatic, meaning they don't have any symptoms, less invasive first. We're always going to try the Valsalva maneuver, the carotid massage that a provider can do to see if they can stimulate that parasympathetic nervous system. If that doesn't work, you jump to adenosine. Adenosine is the medication. You want to slow the heart rate down. You can try some other beta blockers and calcium channel blockers, but typically when somebody is in SVT, we want to try to convert them. And adenosine tries to convert them back to a normal sinus rhythm. And paroxysmal means the sudden stopping and starting of this rhythm. So that's what adenosine does. It stops the heart and it tries to reset it to go back to a normal sinus rhythm. So it's a little scary. There is protocols around this, but it is a conversion drug. We give up to 3 doses. We have to push it very fast, usually over 1 to 2 seconds, and we are putting into the closest IV, closest to the heart, and we are rapidly pushing 6 milligrams as the first dose, and then we follow it with we slam basically 10 cc's of normal saline right behind it because we want to get that specific drug to the heart as fast as possible. Then we need to have the crash cart by them because we're stopping the heart. We are trying to reset this. And if that doesn't work, we can use up to 2 more doses, up to 12 milligrams. But again, we have the crash cart beside us because it's scary. So you have to educate the patient what's going on, what we're doing, and that they're going to feel the effects of this. So typically you want to give them some type of sedation. Now, if they're unstable and we've tried adenosine and it's not effective, then we will go to immediate cardioversion. And then radio frequency ablation is something that they would do in an outpatient clinic or in the hospital setting where they're trying to reset the accessory pathway. So that's how you treat and what supraventricular tachycardia is. So I hope that makes sense. Follow up Professor Molly for more nursing tips.